So I want to talk to you about environmental health as a priority cross-cutting issue. How does the environment impact our health? Many of us working, I'm primarily focused on low and middle income countries, and I work a lot in humanitarian action. A lot of what we talk about is WASH, water, sanitation and hygiene, which is the second one there. If you were there for the previous session, you would have heard me talking a lot about air pollution as an issue in relation to child protection in particular. Climate change being the greatest threat to global health in the 21st century as allocated by The Lancet back in 2009. And other issues as well, including occupational risks around health and safety, and even noise as well, which we don't even talk about. But I think noise in Europe is the second biggest environmental determinant of health. Rory, thank you. So this is what I talk about most of the time, is shit. And I spent most of my time looking into toilets or looking around toilets. So this is a particular classy example that I saw in Pakistan in 2006 following an earthquake in Azad, Jammu and Kashmir. But the picture just to illustrate, WHO estimated a quarter of all deaths, 12.6 million per year or 1,400 per hour, are directly caused by environmental factors. So a lot of us working in low middle income countries are focused on the fecal oral transmission route for communicable disease control, but there's a lot more to environmental health than WASH. So we look at the Sustainable Development Goals. So a lot of us have our focus obviously on the Sustainable Development Goals. I'm going to highlight a little bit around SDG 3, SDG 6 and SDG 13, which are particularly relevant to environmental health. So SDG 3 says, ensure healthy lives and promote well-being for all at all ages. So what does that mean in terms of environmental health? How does an environmental health have a cross-cutting role or a direct role in addressing a lot of these targets? So ending preventable deaths of under 5 children. The two biggest killers of children under the age of 5 globally, respiratory infections and diarrheal diseases. We mentioned the relationship between air pollution and respiratory health earlier on in relation to pneumonia and chronic obstructive pulmonary disease, amongst others. And we're all aware of the link to diarrheal diseases, and we all go back to 1854 and John Snow, the father of epidemiology. By 2030, end the epidemics of AIDS, TB, malaria, and neglected tropical diseases. Well, malaria is a particular problem in the under 5s. Most of the deaths are in the under 5s. Most of it is in sub-Saharan Africa. A lot of emphasis around vector control, drainage, behaviour change around using bed nets. That's a role for an environmental health. Neglected tropical diseases, I'm currently involved in looking at trachoma. The global strategy for dealing with trachoma is surgery, antibiotics, facial cleanliness and environmental improvement. So the F and E is the element of WASH that deals with dealing with trachoma. And you can think of dengue fever and other neglected tropical diseases as well. NCDs, you heard Barsha in the last session talking about active travel. There's a lot of stuff that environmental health does in relation to addressing the non-communicable disease burden, which accounts for 72% of all deaths globally. Road traffic accidents, 1.2 million people die on the roads every year. Air pollution, I mentioned earlier on, over 7 million people globally die from air pollution. An almost equal split between ambient air pollution and household air pollution. And then tobacco control, 6 million people per year die from the effects of tobacco. In Ireland we're going down, but consumption patterns in other parts of the world are going up. Rory. SDG 6 is about water, sanitation and hygiene. We're all probably very familiar with that. I don't need to go into it, but 900 million people still defecate in the open, so there's a lot of shit in the environment and a lot of pathogens in the environment. And then Sustainable Development Goal 13 is around climate change. Climate change is an environmental health hazard of unprecedented scale. And we have to take urgent action to combat climate change and its impacts, and we have to integrate climate change measures into our policies, our strategies and planning. So everything that we do has to have that element of environmental health incorporated into it. And then if I want to make some specific reference in terms of why it's cross-cutting on some other SDGs, we can think in relation to nutrition. I don't know if you've heard of the expression shit stunts. There's a strong correlation between exposure to fecal transmitted infections and nutritional outcomes. So if you are exposed to a lot of fecal coliforms, you will not deliver the same degree of nutritional outcomes as you might otherwise have to expect, and WASH plays a big role in that. And quality education. Again, a lot of children going to school do not have access to the basic services of water supply, sanitation, and hand washing facilities, and particularly in relation to menstrual hygiene facilities that aren't there either. A lot of girls don't go to school, and that can also impact on the gender equality SDG as well. So the bottom line is we need to stop thinking about WASH and start thinking about environmental health as being a critical determinant of health, both globally and also locally. Thank you very much.
This project started during our internship with Oxfam that we thanks very much for their support. As I said before, this study was conducted between me and coordination with my two classmates, Ben Hogan and Malika Parker. Our focus was to find models to finance universal healthcare in Malawi, as the government really wants that, and also WHO actually advocate for that. So a general overview on Malawi. Malawi is one of the least developed countries in the world, largely because of its economic structure and the rapid population growth. Growth is not equally distributed around the country. Inequalities and poverty is very high, especially in the rural area. A key feature of the economy that I feel it's important to notice is that the majority of the labor force is actually involved in informal work, and therefore that creates like a very small tax base for the government. There are different challenges in the deliveries of a quality service. Most of them are operational and structural, but today we're going to focus on the financial part. So the government of Malawi allocated just 9.5% of their national budget towards the Ministry of Health, which is very far from the 15% of the national budget prescribed by the Brugha Declaration. Historically speaking, foreign investors and foreign donors have actually filled the gap of health expenditure, covering up to 61.6% of the total health expenditure. But this is not a reliable source of funding because it's very volatile. An example is what happened in 2013 when major donors there suspended aid fundings in light of the Cashgate scandal. Another financial challenge is out-of-pocket payments and the bypass fees, which are a major burden for at the household level. So we have lots of recommendations, mainly we're going to focus on the financial one as well. We recommend to implement an hybrid progressive universalism model, which is an insurance that covers the whole population, but targets like those diseases the most affected poor to ensure that they are able to access to health services. This model is going to be financed by a compulsory taxation as a percentage of people's income. We recognize that in a country with a small formal economy and therefore a small tax base, a payroll taxation with working co-payments cannot finance the entire health system. But as I mentioned before, we recommend a key basket of diseases that are the one with the highest burden on the community. This approach will allow for a greater targeting prevention and management of these diseases, and will free the space of the budgeting for effectively actually fund other components of the social health package. So Malawi's history of corruption does not inspire confidence in the political system, since funds for health especially can be appropriated for different purposes. Therefore, we believe that health funds should be kept separate from general public funds, and therefore we recommend to create a specific health fund. This allows the accumulating of funds for a specific purpose while generating the revenues over the accumulated capital. This is a self-sustaining income, and even if it does not generate a large amount of revenues, it still could provide a stable source of funding for commodities, or also be a reserve in case donors withdraw their foreign aid. Malawi should move to improve their taxation collection and auditing processes. We were considering different types of taxation that usually are suggested for sustaining universal healthcare. Any financing scheme that we consider, we're taking into account the socioeconomic background of the country, and also they are all progressive in nature. The main taxation that we think are viable in Malawi are fuel levy, sin taxes, and visa, and a proportion of these taxes should be directly to fund the health system. So in conclusion, it's clear that making universal healthcare a reality in Malawi will require a drastic reshape of the taxation system, and also a significant efficiency improvements. This burden is actually possible to overcome. Donor support is going to be very fundamental in this transitional phase, since it's very important and necessary for them to fund their health systems, as Malawi attempt to transition to a domestically financed health. And the government of Malawi should engage with donors with a view towards taking on occurring expenditure domestically and utilizing foreign aid for major capital projects or financial training purpose. So in this way, a sustainable financial model, as the one we try to suggest, can pave the way towards achieving the ultimate goal of wealth for all Malawians, independently of their ability to actually pay.
I'm presenting on behalf of Balamu because they were unable to come. So they're an organization I volunteered in Uganda with. I'm a medical student, and I have a background in research with universal health coverage with the European World Health Organization. So I'm helping them pilot this program in level 1 and 2 healthcare centers, so primary healthcare and small hospitals, to deal with some common issues that I think Malawi also faces to do with access. So these are the 4 issues that they're trying to tackle. And they've started this pilot in October, where they got permission from the Secretary of Health, the Deputy Secretary of Health for Uganda. So I'll just briefly mention each problem and then each solution that they're piloting. So 65% of health facilities have stockouts, which is probably an underestimate. All public health centers have a 2-month delivery cycle on their drugs, so you can only receive new stocks every 2 months, which is just so impractical. And they come from the main warehouse in Entebbe, which is in the south, and we're piloting this in the north, so it's just ridiculous, the logistics of it. So a lot of drugs run out before the 2-month cycle, and some are over-ordered. 25% of prescriptions are not filled, and this means that doctors either substitute drugs that they have, or which can lead to antimicrobial resistance or unsafe treatment, or that patients have to go to the local pharmacies to buy drugs themselves, and these pharmacies have generic medicines from India, which the efficacy is unknown. We can skip that. So their solution is a weekly pull system. So they've agreed with the National Medical Store, which controls all the drug supply in the whole country, to reallocate the orders with weekly orders. So it's a 5-day lead time, and Balamu will pick up these drugs and deliver them every 5 days to the health centers. And then they'll establish local central stores so that if there is a stockout, they have nearby access. And then they'll double the current drug formulary from 35 items to 70. So currently the order form for these health centers only has 35 drugs or supplies that they can pick from. And they're going to prevent theft, which is very common with keeping an inventory, which it seems practical, but a lot of these health centers don't have inventories. So the second problem is absenteeism in the health centers. A lot of doctors operate privately on the side because they're paid more, and a lot of nurses and midwives have to tend to their families, so they leave when they want. There's no time clock, you know. So this solution is going to be controversial, I'm sure, but we want to hear your opinion on it. So they're going to install these biometric time clocks for the staff, which we're going to see what happens. So they have a fingerprint and facial recognition, and they're going to get all the staff to use those daily, before and after lunch as well. And then the third problem is poor medical record keeping. The patients in Uganda, if they're in a public healthcare facility, they bring their own little notebooks that they just bring from home. and it's just, piece of paper, and they ask the doctor or the midwife to write exactly what their treatment is or what their diagnosis is, and they bring that with them every time they present. So there's no record in these health centres from the patients. So the only data that's collected is for the WHO disease statistics, and that's it. So also the maternal and child health cards, they don't record that data either. They just give it to the mother, but they don't keep a copy for themselves. So Balamu is going to give each health center a computer and printer, which seems really simple, but they're going to use Amazon as a cloud host to use EMRs. And the Secretary of Health has asked that they do this in the whole country. So they're going to pilot it, and then if it works, they'll do it everywhere in Uganda. And the HIV data is already on file. That's the only data that Uganda keeps on file, so they'll transfer all of that as well. And finally, the fourth problem is a lack of local autonomy. So the district health officers don't have any autonomy. It's a top-down centralized health system. So even if they want to change things, they don't have the opportunity, they don't have the budget, because everything's controlled from Kampala, the capital city. So we've seen dentists that are paid to work, but they don't even have equipment. We saw one without a dental chair, so they can't work, but they're getting paid for it. And there's no local money. So they're going to start having local meetings with the district health officers and the local mayors, and make working groups with key performance indicators, and they'll give them a local budget so that they can make changes locally and facilitate team building meetings every week. And then, of course, they'll use an M&E strategy to see if this works. And for the patients as well, they'll do satisfaction surveys. Yeah, so that's the district, or this is, one of these is the Ministry of Health, yeah. So, yeah, I don't know if you have feedback for them, because some of the things are a bit controversial, but it would be good to hear some feedback.
I'll be presenting a project that I led, a 3-year project, how to measure performance among community midwives in Sudan. It's an implementation research study. So a little context. Well, Sudan is in Africa. We have serious human resources for health issues. There's critical shortage among health workforce, skill mix imbalances, ratios of doctors to nurses are 4:1. There's geographical maldistribution, where 70% of our health workforce treats 30% of the population. And there's serious issues among performance, regulation, and productivity of the health workforce in general. So our health system is also affected. Health expenditure is at 9.8. And the separation of the South back in 2011 led to the loss of 75% of our oil revenues, which affected 30% of our national budget. And with the US economic sanctions and the global recession and all this, it weakened our further health system. Now, it had terminal effects on maternal and child health. In 2013, the Federal Ministry of Health did a mapping exercise to see where we are at. And they found out that we would not achieve the health-related SDGs. So what happened was that they adopted universal health coverage, a primary health care expansion program, and among one of the objectives was to produce frontline health workers. Now, migration is also a serious issue. 60% of Sudanese doctors work out of Sudan. A lot here in Ireland. So how can we retain people? So they thought about actually producing frontliners, and among them were community midwives. Now, there was a calculated gap of 14,000 community midwives, that have been reached. So as of this year, they produced 14,000 for the whole country. Okay. Sorry for that. The project objective was to develop a practical measure of performance among community midwives. How? First of all, we looked at, we did a systematic review to determine how to measure performance in general of maternal health workers in low and middle income settings. And then to develop a contextually relevant tool to measure performance among community midwives and to validate that tool. Next, please. So implementation research methods was adopted using a system thinking approach, mixed method studies. So as I mentioned, phase one was a systematic review. We were looking at, okay, since 2006, the World Health Report issued and stated clearly that there's a critical shortage of human resources for health. So since 2006 up until 2017, when the systematic review was conducted, what was measured? And when we want to say we want to measure performance, what are we measuring and how are we measuring it? So a systematic review was conducted, phase two, field trips to Sudan, mapping of the health system stakeholders, and then sitting with 13 key informant interviews, conducting a number of focus group discussions, implementation research workshops with community midwives, with the reproductive health state coordinators, and asking them, how do you define performance? What characteristics would you measure if you were to measure performance, and the modality? So basically understanding the context and then trying to co-design and develop a tool that would actually measure performance. Now, 2 rounds of Delphi surveys were conducted with the key informants and the reproductive health state coordinators. And then after that, we had a draft of a tool that actually measures performance. We validated it. 2 rounds, 282 community midwives actually had the survey done. Next, please. So we have a tool now that's nationally endorsed by the Federal Ministry of Health, and it looks into performance and specifically looks into these 6 constructs: knowledge, compliance, competency, job satisfaction, supportive supervision, and work motivation. And for those who read Arabic, this is it. So by implementing implementation research, we were able to develop a contextually relevant tool that measures performance based on the national context and validate it.